Hi, 3164. This is Dr. Ang with you today to discuss ethics, specifically related to patient rights and then informed consent. So, we're going to dive right in to learning outcomes. And today we're going to go over just review the basic principles of ethics in general. We're going to examine the ANA Code of Ethics, ICN, and Principal Patient Bill of Rights. We're going to touch on that, and then the practical implications, the take-home points of how that will impact you as a nurse. We're going to discuss the role of the nurse in obtaining informed consent, and then analyze conflicts of universal principles in obtaining consents. I have throughout the PowerPoint as well, you can see there will be links that you can go off and see. It's usually going to be referencing resources that are going to be beneficial for you. There are also some videos that kind of takes a little deeper dive and rewords it, says it in maybe another way or manner that might be more meaningful to you. Things that I found helpful in my practice, so I want to share those with you as well. And as I always preference, before we begin, I just want to let you know if there's anything I'm going to highlight on the need to know information. Obviously, focus as you study for the exam. Focus on those areas. Let that be kind of your study guide for this content. But then if there's anything that just piques your interest and you want to take a little deeper dive, I'm more than happy. We can set up a Zoom meeting, whatever would be beneficial to you, because I'm more than happy to take that deep dive with you. Love to discuss ethics. It's one of my favorite places I find in my wheelhouse that I love to discuss. So never a bother, and always a welcome invitation if you want to take a deeper dive with ethics. So required readings. Again, we have our textbook. You can look through several again of the references here are resources that you can find on the web, ones that you might want to bookmark on your laptop and just have available for resources moving forward. So autonomy. When we think of ethics and we think of patient rights, we automatically, what should come to mind is autonomy. That is personal liberty or the right for self-determination. When I am in a clinical hospital setting, I want to know that everything, every intervention, everything that's implemented in my care and incorporated into my care, I want to know if I'm able and I'm competent and able. I want to know that I have spoken to that and I have specific desires for my own health care, and I want to know that those are considered. And that as a nurse and part of the healthcare team, that is what we want to offer our patients. So the right for self-determination. And what does that mean? When you think of as a nurse and you're caring for multiple patients, that means there are multiple opinions, thought processes that go into play. So being mindful of that, it's not a one size fits all. It's not a blanket statement that says this is what we do in this case. It's a case-by-case situation because we know that each patient has the right for autonomy, the right to determine their own care, personal liberty. They have that freedom. That is their inherent right to be able to determine what's best for them in this situation. And then just self-determination, that we can foster that. The ability to decide, give them choices, even if it's small choices. So speaking in the lenses, I look through the lenses of a pediatric nurse. Some things they have control over and some they don't. And something about the minute you enter a healthcare facility or a clinical environment, you feel as though you're somewhat stripped of every right to choose for yourself. You feel all my privacy is now gone. What I think that I have control and power over, now all of a sudden I feel like that's being stripped from me. So as a healthcare worker, as a nurse for specifically pediatrics, I'm going to ask them, even if it's a small thing, like, would you like apple or orange juice? Would you like me to put this here, or how about over here? Would you like to go for our walk before you eat, or would you like to go for a walk after we eat? They're still going to get the walk. They're still going to have the intervention, but you're just letting them have the right to decide for themselves, power to act upon their decision. So although there are some very controversial topics out there, and if I'm discussing that, let's say with a teenage girl, and even if I don't personally agree with her decision, if she has the right for self-determination, the ability to decide, then there should be that power to act upon that decision if that is in the well-being of that patient. And so in other words, don't make it available and don't make it an option if it's not something that can be carried out, because there has to be action behind that decision. Respect for individual autonomy of others. So this is just in general, just a general respect. It's kind of a given, but sometimes we need to look at it through the healthcare lenses. So some of these you would think would be something that you would just know and would be natural to do, but then sometimes it's not, and especially if it goes against your personal code of ethics. Remember, we've discussed, there's a lecture that we'll go over, and it's your personal code of ethics versus your professional code of ethics. And when those merge, it's a beautiful thing and it feels right. But when those don't and there's a conflict, it's kind of a butting of heads and it feels rather uncomfortable. But in that instance, if you're working in a role, that professional code of ethics states that you will respect the self-determination of your patient. So even if that collides with your personal code of ethics, you have that obligation as a nurse. So I say that in just to encourage you when you're looking for a role, like where will you work and where will your career setting be? Take that into consideration. If you have, if you struggle with end-of-life issues, that maybe would need to determine that maybe you would steer clear of certain areas. If you have issues or concerns or struggles with certain areas when it comes to do with maybe teenagers and different things there, or when it comes to when does life begin, when can it end, these different things, if they're controversial to you and that doesn't set well with you, then there are different settings that may be a better fit. Some people embrace that and love it and thrive in those areas, but just when you're looking through your ethical lenses, do consider your personal code of ethics and how that will mesh with your professional code of ethics, because in that role, you are to be respectful and mindful of the patient wishes and their right for self-determination. Universal principle of biomedical ethics with autonomy: respect choices to refuse treatment or care. There are some nurses, and I say this in general, any part of the healthcare team, because we are that. We are a collaborative healthcare team. It is difficult when a patient comes in, and if they refuse treatment or care, that can be difficult for a nurse as well. But under the umbrella of autonomy, that is our obligation. Impermissible to lie or withhold information. Okay, yeah, that is a universal principle, and we cannot lie to the patient, and we cannot withhold information. However, there is a process in which certain information should unfold for a patient. And if there's a test result back, and the provider is going to meet with that family to explain the current situation, that is not your role. If a child, for instance, asks you, am I going to die? Or is the test positive? And you know that, you don't need to lie, but you can say things like your provider or whoever, the name, obviously, your Dr. Jones, whatever, nurse so-and-so, if it's a advanced practice nurse, are going to be in at 2 o'clock, and they're going to discuss all that with you. So for me, I always want to give hope and be positive. Obviously, you're not going to impede doom and gloom and then pass it off where now they're going to worry about it all afternoon. But you can also then let the provider know that they are asking questions and they're eager for them to come in and discuss the results with them. But it is impermissible to lie and to withhold information if that is within your role to provide that information. Impermissible to deny informed consent. If a patient is scheduled to have a invasive procedure, surgery, whatever the case may be, it is their right to have informed consent. So it is unexcusable, impermissible for you to deny a patient the right to choose whether or not they want that procedure. And respect and provide privacy and confidentiality. Obviously, this is a huge one with HIPAA. We know this. However, we need to be reminded of just how big this is actually a universal principle of ethics. Reasonable efforts to act in ways that benefit another, promote health, welfare, and safety. We are to promote good. If we know there's something that would help a patient, if it's more information, if it's additional resources that would make aid and assist in them meeting their optimal outcomes, we are to provide that information. We're to promote good and things that can benefit that patient. And it's actually harmful to a patient if I have information and I'm taking a long time to get in to, I can't, or maybe it's a pain medication. I know that they're in pain, and yes, I am going to get it in there on time, but maybe I could have sped things up and reprioritized and got it in there in a safe but yet early manner. Maybe I could have brought it to them before I went down to break, even though I'm technically administering it in the appropriate window. I'm not neglecting them, but if I'm promoting good and I want to benefit that patient, then I want to put their needs top on the priority list. And obviously you have a lot of needs and we have to negotiate that constantly throughout the day, throughout our shift, but just being mindful of that, of doing and promoting good. Maintain competence. It is my obligation as a registered nurse to remain competent in the roles that I'm in, whether that's pediatrics at the bedside, whether that's a legal nurse consultant, whether that is someone that is in the emergency room and there's certain credentials or certifications that you need. Whatever the case may be, we need to maintain the highest standard, the highest level of competence that we can. If you're working in an institution, a hospital for say, they will have certain guidelines that you need to meet, and you need to maintain certain clinical hours, whatever the case may be. Oklahoma Board of Nursing also oversees that and makes sure we have the continuing education credits that we need. So for our profession, for us to remain a highly trusted profession, we must be competent in our role, not just show up and do the same old, what we've always done, but we need to be cutting edge, following research, evidence-based practice. Are we doing the best that we can for our patients, given what we know? And in order for us to know, we need to be in touch. We need to have our hand on the pulse of new and cutting information so that we can constantly be giving the best possible care. Promote own mental, physical, emotional, and spiritual development. So as a nurse, you can relate this even to a mom or dad. If you are always giving, you need something to give, right? You need that energy. So what is it that can fuel your soul so that you can in turn fuel someone else's? So take care of yourself. Physical exercise, you may think, I'm on my feet all day, I don't need any exercise, I don't whatever. Physical exercise, when you can just blow off steam, you can get those endorphins going. All of this, that's positive health, taking care of yourself. Whatever it is that can protect your emotional health, your spiritual health, and only you know that for yourself, but prioritize that. If you're a planner and a scheduler, put that on your schedule so you can make sure you take time for yourself. Non-maleficence. Don't impose unreasonable risk or harm. Okay, so we just said we want to promote good. Beneficence is a term. Now, non-maleficence. Don't impose unreasonable risk. And this is, again, one that seems simple, but I like to reference a lot because it's something that we see so often, is that of pain. Why would I send my patient to physical therapy knowing that this is a post-surgical procedure, this is going to be difficult, this is going to be painful, why would I send them without offering a PRN pain med, or their pain med's not technically due yet, but maybe I could have collaborated a little bit better with physical therapy and said, can I get their pain med in? We give them 30 minutes or so before you send someone to come and get them. Just things that you can do. Why risk harm? This is even similar to as a nurse when I'm in a patient's room. If I see something has spilled on the floor or something is leaking, am I going to go out of the room and delegate that to someone else, and then hopefully within the next hour someone will get in there and clean that up? Or if I don't want to impose any risk for harm, maybe I can take the initiative and actually clean that up and put patient needs at the top priority, because I don't want to cause any overlook anything that could cause a risk for harm. Do not harm with slander, insult, or ridicule. This is one that I see. I like to just give random examples, and there are so many, but this is one that is often seen in giving report. We don't need to talk about the crazy lady in room 208, or the needy family, or have you heard the story on 412? Can you believe that? Isn't that awful? Or this is the one that was on the news. You didn't see the story? Let me tell you all about it. That we don't need that, okay? And this is also not just healthcare team to patient. This can also be nurse to nurse. I came in and had to do all this because I followed lazy Johnny, the night nurse. No, that's not. That just creates a culture that's negative, and we're not able to thrive in that. And who does that affect ultimately? It ultimately affects our patients. So staying above that is critical. This is also not the time to, if you have a patient, and yes, they may have came in several times for non-compliance, but rather than ridiculing and talking down or talking behind their back and us thinking that they don't hear, but trust me, they hear, family members hear, or other patients and family members hear, and that does not present well. That is not the billboard that we're trying to send for our profession or where we work, or for ourselves. But if this is the if it's non-compliance, maybe find out why. And maybe in a spirit of caring and concern, we can find out that maybe it's not that. Maybe it's that they don't have transportation, or funds are limited and they really want to do right, but they're doing the very best they can with what they have at the time. And it does not help to ridicule in someone in that situation. Also, if it's maybe a long-term care facility and the patient is trying to get up, or they're moving slower than you want, and you have a to-do list a mile long, can you have patience and encourage, or are you going to have a spirit of insulting or ridiculing your patient? And that, remember, that can be verbal and nonverbal clues, so be mindful of that. Do not steal others' property, including intellectual. This is obviously, we know in several instances somebody may go down for a procedure and they leave valuable things, money, rings. This can even be glasses, dentures, whatever the case may be. Obviously, we're not to steal, but going a step further in doing good, maybe we can put that in the top drawer and let them know where we put it, or we can talk to a family member about maybe taking that home, because we want to protect our patient. We want to promote good, and all of these things come together to providing where they can trust us and they know we're there. They're more apt to listen to us and encourage and receive the information that we're telling them if they feel there's a spirit of unity and we're there to help them. We're there to promote good for our patients. It's much more welcoming in that case. Then, obviously this one, hopefully this does not need to be said, but it's here. Do not engage in inappropriate relations or sexual interactions with a patient. Hopefully that is a given. Do not steal others' property, as we mentioned, but what I didn't hit here was intellectual property. So this is even in nursing school. This can be plagiarism. This can be someone else does the work. This is whatever. Just be mindful. If it's not yours, get either permission, stay completely clear, or give rights to who they are due. Universal principles, again, fidelity, promises, do what you say you're going to do, or don't give specific time parameters. I've even learned with pediatrics to just use the term flippantly, I'll be back in a minute. No, you won't. You probably won't, and they'll take you literally. So I will be back after lunch. After lunch can be a lot bigger span, or I'll be back this afternoon, or just I'll be back. Call me if you need anything, but don't give specifics. Don't make promises you can't keep. You will be discharged tomorrow. Do you know that? Maybe they will, maybe they won't. Things change. Confidentiality, again, referencing back to HIPAA. For some reason in healthcare, we can tap into, if we're not careful, being the powerful distributors of great stories and great information that can pique interest from a lot of people. And just because we are privy to that information does not mean that we need to be sharing that information. So keep tight-lipped with that. And now even with the different electronic systems that we have in hospitals, they're tightening up that if you're not caring for a patient, then you don't need to be viewing their medical records, and there are tracing being done now to make sure that doesn't happen. But in some cases you are caring for that patient, and still we keep the information with only people that need to know that information, and it is not a course of topic of conversation just amongst our family and friends. Examine the ANA Code of Ethics, Patient Bill of Rights for practical implications. So I'm not going to read all these to you. We discuss these in greater detail when we have in-class sessions, but they are very self-explanatory. Hopefully none come as any of a surprise to you. Compassion, respect, dignity for all, primary commitment to patient. These are all ones that we've already hit on. And you can look down at the bottom of this slide and you can see, you can tap on here and see, it'll take you to a link. Make sure that you are aware of where the Code of Ethics are for nurses, because as I've mentioned before, we are responsible for that Code of Ethics. And if you're ever named in a legal suit, this will be referenced. And it's never an excuse to say you didn't know or you weren't aware. So you want to make sure that you read through this list and you know under what umbrella that you should be practicing. And again, hopefully they're not any surprise to you, but it should just be a reminder. And it's a good idea to just reference this just to make sure, kind of a little accountability check for yourself. Have a couple little cartoons on there if you want to dive into that. Here is another book that you can see. If you're into this and want to take a deeper dive, I can share lots of resources that are actually very helpful. If you want to do any research or follow any studies with regards to biomedical ethics, anything of this nature, but in the ethical or legal realm, please let me know, because we have some great resources at our fingertips. And a lot of these books and references I have access to the electronic version. So if you're interested, let me know and I can share some information with you as well. So glimpsing into patient care partnership, a document that replaces the Bill of Rights. You can tap on this link and it will take you to here, but this is the patient care partnership. Patient Bill of Rights is moral rights are believed to be inherent. So this is just, you are a human. When you are born, there are certain rights that are just inherent. A policy document that presents the official position of the American Hospital Association on the moral rights of a hospitalized individual or someone that is seeking professional health care. That determines healthcare ethics and the Patient Bill of Rights. There are certain rights that when you come and you seek health care that are inherent to you, just as a human seeking health care, there are certain rights that you have. The Patient Care Partnership, again, another word for Patient Bill of Rights, respect for values and dignity, detailed information about your care, decision-making, privacy, confidentiality. One that I've heard a lot when speaking with patients is they don't feel that they get enough information. When you're closed up in, especially in a hospital room, and you're sitting there and you are not a healthcare professional, you don't know what's going on. If someone doesn't tell you, you don't know that you're waiting because it takes a certain amount of time for the blood work to be sent off or the medication to come up from pharmacy. You don't know. You're not privy to that information. That's not common knowledge to you as a patient. So as a healthcare team, we need to share that information. Don't assume that they know that. Don't leave a patient waiting all afternoon if we know a certain time frame. Or if I know that this doctor makes, or provider makes rounds every afternoon at between 4 and 5, don't leave the patient waiting all day and they're becoming frustrated, and that's not helping them with their overall goals. If they're sitting and they're stressed and frustrated and they're starting to think the worst, how come no one's coming in here? Just offer what you know, do good, and provide detailed information, facts that as you know them. Helping with decision making, giving them both sides of the coin and letting them exercise autonomy and choose what's right for them, privacy and confidentiality in all that they do. You can look through here, Affordable Care Act. We don't need to dive too much into this, but you can be aware of that. Okay, this is one of the biggies on this lecture is, what is your role as a nurse in informed consent? I like to play some little role play games here, but since we're doing it in this manner, I'll just kind of stay with the highlights and give you some examples as we go. So active shared decision making between the provider and then the recipient of care. Just remember, it's critical with informed consent that it is a collaborative effort. It is a collaboration between the provider, between the recipient, so we'll refer to as the patient, and then the nurse in this case is going to also be in this collaborative effort. And we need all three pieces in order for the informed consent to be obtained. It's true with written, oral, and implied forms of consent. So written consent is you come in, the provider gives all the information, the risks, the benefits. Okay, first, what is the procedure being done and why is it being done? What are the risks and benefits of having this procedure? And then what are my alternatives? What happens if I don't do anything at all? Or is there something less invasive I could try first? So I need to know the risks and the benefits, and I need provide a detailed assessment and a description of what's going to happen. And then I need to make sure that that patient has the ample opportunity to ask questions, that they comprehend, and that this information is given and presented in a language they understand, and that it's a level. We don't need to talk in high healthcare terms that we barely understand. We need to bring that down so it's in a manner that they can comprehend, and they can understand and receive that information in order to offer and support autonomy and for them to make the decision themselves. So, and then oral is, there is not time to get the paperwork and do all that, but we're in a little bit more of an emergency situation, but the person is fully capable and competent in giving their consent for surgery or any invasive procedure. And then implied forms of consent, that's going to be more in a situation, someone was in an accident, this is an emergency situation, there was a gunshot wound or whatever. We need to act fast. There's no family here yet. Obviously, the patient can't consent for themselves. This is implied consent. And unless we have some documentation somewhere stating not to implement life-saving measures, then we will have implied consent and move forward in that manner. Elements of informed consent. Again, condition. What is the problem? What's the treatment that we're going to use? Nature and purpose of the treatment. So what is the point? What is it going to do? How is it going to help remedy the situation? Feasible alternatives, consequences of not treating, prognosis, risk, and benefits. So this is some of what I just mentioned. These are the elements of an informed consent. Informed consents are required for any type of surgery, major or minor, diagnostic testings with an element of risk, anything basically that's invasive, medical treatments if there's a risk of clinical research. It's important for us to be mindful of the fact that although we're doing research, even if it's in an institution-wide, we're conducting a study, although that patient is there and we have those records, we cannot just utilize that information without patient consent. So this is one that sometimes is forgotten, that this is part of informed consent as well. The IRB bringing out that whole can of worms right there, but the IRB, and knowing that clinical research requires each patient to consent to be part of that study and to offer their information. A nurse can witness the patient's signature. Critical, one of the most important slides, this statement right here. The role of the nurse. I just described what all the components are of informed consent. What's the procedure? Why do I need to have it? What are the risks and benefits? What happens if I don't have this procedure? All of these, the alternatives to that. That is information given by the provider. Who's actually going to provide that service is who gives that information. The role of the nurse is to witness that signature and to ensure that that was given and presented in a language that they can understand, at a level that they can understand. If we need to get someone to sign language, if we're hearing impaired, if we need to get a translator, whatever the case may be, if the provider comes in, they give that information, and for whatever reason, as that nurse, in that collaboration of obtaining this informed consent, if we feel, I don't think they fully understand that, they are asking me questions that indicate they did not fully grasp that information. They either went too quick, they were speaking over their head, they didn't give time for questions, or it's someone that needed an interpreter of some sort, a translator, and they did not have access to that. In that moment, what do we do? Do we further explain it? Or do we get a translator and then we try to read the fine print to the patient? Absolutely not. What you do in this moment is you call that provider, you call them back, and you need to go through the process again until that patient thoroughly understands in a language and in a level that they understand, that they can fully comprehend. The nurse verifies signatures and signed signature on the informed consent, and then that goes on the chart for surgery. Informed consent required for, again, discharging, post-mortem examination, another thing, organ donation, examination of medical records. All of these things we need informed consent. So no coercion is allowed. So this is one that's critical when occasionally you'll have a provider that likes to provide a certain service, and you may feel a level of coercion in, yeah, you could have that done, but you probably should go this route. Or you could have a procedure that, yeah, that may help, but you know what, this may have been a better option for them, but you didn't really even offer this, and you made this sound so good, they followed your recommendation as a medical professional, and there was some coercion involved. And we know the difference when you're trying to steer someone a certain direction. It's self-determination. You get, the facts are presented to the patient and they choose. There's no level of coercion or benefiting yourself based off of their decision, or even something as simple, I gave them an option. I know in the end that's going to be more work on me, or that may affect me in some way, or I may benefit if they choose this procedure. In the case of a provider, sometimes there are unfortunately kickbacks where they may tend to lean or prefer to do one or the other. And if that's not perceived as in the best interest of the patient, that needs to be brought to the forefront in that moment. Must be competent, given in a thorough manner, notify physician of patient's questions. So again, that provider needs to be contacted immediately if, as the nurse, we feel they still have questions afterwards. Respect client's choices, even if you do not agree. So again, excuse me, we've talked about written, which is preferred. Nurses witness the schedule, the signature on the informed consent. Oral, it requires collaboration. There's not anything that you're going to do on your own where you will obtain an informed consent, just you and the patient. That is not going to be the case. There will always be a provider there, providing information, as well as that will provide ultimately the procedure. But it's a collaborative effort. Implied, used when immediate action is needed to save a person's life. General, and informed consent is routine service for admissions just to the agency in general. You'll have to come in early, you go through all your paperwork. Informed consent, that you're allowing them to treat you. And then special informed consents, this is just throwing into a pot high-risk procedures that there are a lot of known risks, and we're going to outline all those. Going into it that it's a very risky procedure. Common factors used to decisions regarding patient competence, patient's ability to make choices about care, sufficient information and intellectual capacity. We've already touched on this. Patient's culture, and their values, authentic and not coerced. Different cultures have different views. You need to be aware of those and make sure that there's dignity and respect in them, helping to honor those as well. Age and maturity. We need to just the competence level be in touch with that. So in some cases, then we need to have who else is assigned to consent for this patient. Comprehension of the nature of the illness, nature of treatments, effects of pain, disability, and depression, attitudes and values of the physician, moral and religious backgrounds, and clinical setting, hospital versus private, physician office or patient home. These are all factors in the decision making for informed consent. So here I have the final few slides. Here we have examples of NCLEX questions referencing informed consent. And then you can tap into these last ones, but informed consent and the right to refuse treatment. Anyone has the right to refuse. That's just that self-determination and autonomy. They can either choose or refuse their treatment. And again, keeping coercion out of it. We give the facts, we provide the information, the resources, everything we can. And obviously we want to help them reach their ultimate outcomes, but every case is different. And you need to have everyone at the table that is involved in that. So when we're talking about pediatrics, obviously we're not just talking about the patient. We have caregivers and who is named to be able to consent for that patient. Competent and informed decisions should be honored. And once they make that decision, then you honor and respect that and you support them. And it should be a nature of just that, dignity and respect. When dealing with people who cannot make an informed decision, a surrogate should be appointed, and we will look at the documentation. They need to have proper documentation. That's why it's so important that you do that now, because if you're in the event you're in this situation, in an emergency situation, you don't have time to start finding a surrogate that can consent. So having that named ahead of time is obviously going to be in your best interest. So with regard to children should be assessed for understanding the ability to participate. They can participate in the process. and this goes for procedures, they can be involved in the information informed consent there, as well as if it's like a research study, they need to be given the information as well. But then you're going to have someone over 18 that will actually sign the informed consent. Once you reach the age of 18, then you take over that ownership and you sign your own informed consent if you're capable and competent to do so. Let's see. So you can follow that final slide there, the takeaways. Basic elements of informed consent include communication with the family or significant others. The persons must receive information such as risk and benefits. You must be competent, and it must be voluntary. Critical thing is there's no coercion. It's voluntary, and then it's presented, whether it's written, oral, implied, whichever. The information will need to be presented in a level, in a language that they can understand. The role of the nurse is to witness the consent. It is not to provide the information. You don't need to provide the backup for the information. You would call the provider back to reiterate and make sure that there's no questions that they need to know. We're always trying to support the self-determination and dignity and respect of that patient. We want to promote autonomy. We want to beneficence, non-maleficence. We want to do good. We want to prevent any risk of harm that we can do. We want to make sure that if someone is unable to provide informed consent, that we find that surrogate who's named in their advance directives, whatever they have in their will, whichever aspects, who is named as that surrogate, who do we need to be communicating with and obtaining that informed consent. Then that will go on to the chart, or that should be a part of if it's an electronic chart, it will be a part of that as well. But the role of the nurse is to witness the signature and to ensure that that patient understands the procedure, why they're having the procedure, the perceived risks and benefits, and then to know if there are any reasonable alternatives to that. What would happen if they don't treat, and what else could they maybe try if there are other interventions to that. But all that information needs to be fully understood when that informed consent is obtained. Thank you very much. If you have any questions, any further questions, please reach out to me, and I hope you have a lovely day.